right now, if a nurse walks into a maternity room in America, there is there's a very high probability that the family sitting there looks absolutely nothing like the traditional nuclear family.
Oh, yeah, completely.
I mean, the image we all have in our heads, the sterile room, the beeping monitors, the very predictable set of steps everyone follows, it's all based on a rigid script that simply doesn't reflect who is actually walking through the hospital doors anymore.
Right, because we are looking at a landscape of human experience that is so incredibly diverse now.
Exactly. The whole one-size-fits-all approach to having a baby has just completely shattered.
And the medical system is, well, they're actively being forced to reckon with this. The patients showing up for perinatal care do not fit into those neat little mid-century boxes anymore.
No, they really don't.
And because of that, the standard hospital-centric model of care is just straining under the weight of an incredibly complex modern society.
Which is exactly why we are thrilled you are joining us for this deep dive today. We've got a really fascinating stack of source material to get through.
Yeah, we are pulling from excerpts from a deeply insightful medical and sociological text called Community, Culture, and Family in Perinatal Care by Jacqueline McMillan Bowler.
Yes. And our mission today is to basically shortcut your way to understanding how modern healthcare providers are desperately trying to adapt.
Adapting to the reality of the beautifully complex family.
Right. And we're going to see exactly why the hospital itself might no longer be the center of this experience. So, okay, let's unpack this.
Let's do it.
Because before we can even begin to understand how medical care is changing, we have to look at who is actually showing up to receive it.
Well, it goes straight down to the foundation, right?
Yeah.
The family unit itself. I mean, the entire Western medical system was fundamentally built around the concept of a married husband and wife living independently with their children.
The classic nuclear family.
Exactly. But the source text points out that this specific family structure is rapidly becoming a minority. Demographics are shifting massively.
Like, how massively are we talking?
Well, when you look at the data in the text, only about 28% of Black or African American families.
Wait, only 28?
Yeah, just 28.8% actually. And 43.8% of Hispanic families are represented as traditional married couples.
Wow. So, I mean, the traditional nuclear family in medicine is, it's kind of like a landline phone.
A landline phone, I like that.
Right. Like, we all know what it is. We understand the concept, but treating it like the primary way everyone connects today is just ignoring reality.
That landline comparison actually highlights the friction perfectly. Western medicine built its entire legal and logistical infrastructure for that landline.
But everyone's walking around with smartphones.
Exactly. And the reality of the modern family is wildly diverse. The text notes that right now, there are an estimated 6 million children in the U.S. living with a grandparent.
6 million. That's huge.
And out of those, over 2.5 million grandparents are the ones actively raising their grandchildren.
Okay, so the grandparents are the primary caregivers.
Yes. And single-parent families are continuously rising, with 21% of children living with their mother only.
Wow.
Plus, you have almost 3 million children being raised by LGBTQIA parents.
So the whole picture has just shifted.
Completely. When a healthcare provider walks into a room, they cannot make a single assumption about who is in charge, who is supporting the patient, or honestly, who the family even is.
Think about the forms you sign at the doctor's office. You explicitly list exactly who can know your medical details based on strict individual privacy laws, like APINA.
Right, the IPA forms.
But if you are coming from a culture where the extended family is deeply involved, that legal framework suddenly becomes a massive barrier.
Well, what's fascinating here is how these changing structures actually dictate the kind of medical care a person needs.
How so?
Let's take that extended family scenario. In many cultures, the extended family provides vital, social, emotional, and financial support. They aren't just, visitors dropping off flowers.
Right, they're not just popping in to say hi.
No, they are an active, crucial part of the medical decision-making process. But the hospital's legal framework says we only talk to the individual patient.
While the patient's cultural framework says, you need to explain this to my grandmother and my aunt because they are helping me make this choice.
Exactly. And if a nurse doesn't understand that dynamic, and rigidly enforces visitor rules or privacy protocols, they might accidentally alienate the exact people who are crucial to the patient's recovery.
Okay, so if the nuclear family is a landline, how does a nurse figure out the new smartphone wiring of the people sitting in front of them?
It's a challenge, for sure.
I mean, identifying the family structure seems like a huge logistical problem when you don't have hours to sit down for, like deep behavioral therapy.
They definitely don't have hours, which is why specialized assessment tools are being deployed. The source material outlines a framework called the Calgary Family Assessment Model.
The CFM.
Yeah, CFM. It allows nurses to rapidly break a family down into three major categories: structural, developmental, and functional.
Okay, so structural meaning, like who actually lives in the house.
Right. And developmental being where they are in their life cycle, like those grandparents raising a newborn we mentioned.
Got it. And functional would be looking at the day-to-day reality of who pays the bills and how they actually solve problems.
Exactly. And to process this quickly, nurses use graphic tools.
Graphic tools, like drawing pictures.
Sort of. The text highlights genograms, which map out health history and relationships across at least 3 generations.
Wow, 3 generations.
Yeah, and ecomaps, which are visual portrayals of a family's social relationships and support systems outside the home.
So it's almost like drawing a quick social wiring diagram of the family rather than just taking a dry medical history.
That's a great way to put it. It takes complex social data and turns it into a map the healthcare team can actually read.
But how do they get all that information?
They gather this data using the 15-minute family interview format developed by Wright and Leahy.
Okay, wait. I have a hard time buying this 15-minute interview thing.
Why is that?
Well, a nurse is practically sprinting from room to room, right? Checking monitors, doing vitals, charting medications. How are they supposed to conduct a deep psychological family assessment and draw a whole social wiring diagram in the time it takes to check a blood pressure?
It sounds like a lot.
It sounds completely impossible in a modern hospital setting.
It's a very common pushback. But the text clarifies that this assessment isn't some rigid, objective psychological test with a clipboard and a stopwatch.
Okay.
It's a therapeutic conversation layered over the clinical tasks. It prioritizes basic manners, asking therapeutic questions, and actively commending family strengths. They aren't looking for one-time occurrences. They want to identify established behavioral patterns.
So it's more about the approach.
Exactly. It's about shifting the entire model of care from illness care to health promoting.
Meaning the nurse isn't just treating a symptom, they are building a quick alliance.
Yes, you are enlisting the family. By actively listening and maybe sketching a quick eco map on a notepad while taking that blood pressure, the nurse completely transforms the family from being passive bystanders into an active interprofessional healthcare team.
Oh, I see.
You find out in those 15 minutes that the aunt is the one who will be cooking the meals for the next month.
Right. So instead of handing the nutritional discharge instructions to the exhausted patient,
You direct them to the aunt. You're working with the reality of their ecosystem.
you're finding the load-bearing walls in their support structure.
That's exactly it.
But identifying the family is really only half the battle. The text says the other half is understanding the invisible cultural rule book that family is operating under.
Oh, absolutely.
When a healthcare provider figures out who the family is, they immediately run into how that family views health, illness, and birth.
It is a profound collision of worldviews. The text discusses the concepts of ethnocentrism versus cultural relativism.
Ethnocentrism being,
Think of ethnocentrism as a nurse looking at a family through a very specific biomedical pair of glasses. The belief that one's own way is the best way.
so to the nurse, childbirth is a high-risk medical event that needs constant scientific management and advanced technology.
Right. That is the Western biomedical model.
And cultural relativism would be taking off the hospital glasses and putting on the family's glasses.
Precisely. Understanding another's culture by its own standards. Because through the family's glasses, birth might not be a medical crisis at all, but a completely normal, natural life process requiring minimal intervention.
That's a massive difference in perspective.
It is. And when a patient from one of those cultures rejects a medical intervention that the nurse thinks is standard protocol, an ethnocentric nurse might label that patient as being difficult or non-compliant.
But it's not obstinance. It's a completely different logical framework.
Exactly.
And this cultural friction goes way beyond just medical decisions to basic human interactions. The text talks about cultural differences in personal space and touching.
Touching is a huge one.
Nurses are explicitly taught they must ask permission before touching a patient, because invading that space uninvited can strip away autonomy and spike anxiety.
Even communication styles differ wildly.
Yeah, how so?
The volume and animation of speech is a major friction point. In some cultures, people naturally speak loudly with very vigorous, passionate gestures.
Right, whether they're expressing profound joy or deep concern.
Exactly. But a nurse who isn't culturally aware might misinterpret those loud, animated gestures as anger or aggression.
Oh, wow. So they might call security or label the family as combative, entirely misreading the room?
Yeah, it happens.
Okay, here's where it gets really interesting to me. The text breaks down how different cultures focus on time.
The time orientation concept, yes.
Yeah, it says some cultures are focused on the past, meaning tradition dictates decisions. Some focus on the future, meaning long-term goals. And some are entirely focused on the present, living for the moment.
Right.
But, I mean, how does someone's cultural focus on the present actually impact their physical health care? Isn't time just time?
You'd think so, but it impacts the very core of how they interact with treatment plans.
Really?
Yeah. If a family has a cultural orientation focused on the present, which often correlates with the day-to-day survival concerns of vulnerable populations, their mindset is anchored in immediate needs.
Okay, make that concrete for me.
Imagine you are a young mother whose primary concern is figuring out how to make rent by Tuesday and keep the electricity on.
Right, a lot of stress.
If a future-oriented nurse comes in and starts enthusiastically talking about scheduling clinic follow-ups for a newborn 6 weeks from now, that information simply will not resonate.
Because they're worried about making it through the week. The future doesn't exist yet.
Exactly. It's not that they don't care about their baby. They care deeply. But their cultural and practical operating system prioritizes urgent, immediate reality.
So if the nurse doesn't recognize that present time orientation,
They will hand over a discharge plan the patient simply cannot process, leading to missed appointments and a breakdown in care.
it's like they are speaking two completely different languages, even if they are both speaking English.
That's a perfect analogy.
But the source text points out that it's not just abstract beliefs about time or birth that cause friction. Often, it is literal miscommunication and deeply ingrained systemic biases that lead to dangerously unequal health outcomes.
Yes, the source text is very direct about the data regarding health disparities.
Right, and just to be clear for you listening, we are strictly relaying the research and findings exactly as they are presented in this text. We're not taking any sides here, just looking at the sociological data.
Right. And the research provided indicates that implicit bias and systemic racism, rather than genetics, are primary drivers for why BIPOC women face disproportionate burdens of disease and much poorer perinatal outcomes.
The text specifically highlights higher rates of preterm labor and low birth weight in these communities.
Yes. And it's important to understand the mechanism the text proposes here. It asserts that these outcomes are tied directly to the physiological stress of discrimination.
Like the stress actually changes the body.
It's a concept often referred to as allostatic load. The chronic stress of navigating systemic barriers and bias actually creates a physical wear and tear on the body.
Wow.
That elevated stress response impacts pregnancy on a biological level, causing those preterm labors. The text makes it a point to emphasize that this is a systemic and environmental issue, not some biological or genetic difference.
And the text also looks at the stigmatization faced by sexual and gender minority groups, LGBTQIA individuals.
It does.
It notes that the bias they encounter in the healthcare system is sometimes so severe that they will conceal their sexual orientation entirely out of fear of receiving substandard care.
Which compromises everything. A healthcare provider cannot provide holistic, accurate care if the patient is forced to hide who they are.
Or what their living situation is, or who their support system actually is.
Exactly. You can't draw an accurate eco map if the patient is terrified to tell you who is really in the room.
Then there's the issue of literal language barriers, which the text outlines as a major risk factor. It provides critical rules for using interpreters.
This is so important.
Because the ideal interpreter shouldn't just speak the language, but should ideally share the client's native dialect, their religion, or their country of origin.
Because language isn't just vocabulary. It's nuance and cultural context.
And the text strongly warns against the danger of using family members as interpreters in emergencies.
Oh, absolutely. It's a huge danger.
I mean, why is that? It seems like it would be convenient.
Convenience doesn't mean it's safe. Using a child, say a 10-year-old, to interpret forces that kid into a highly inappropriate adult role.
Oh yeah, translating terrifying medical terms about their own mother. That's awful.
Right. Or consider using a male relative to interpret for a woman who needs to discuss very sensitive reproductive health issues.
Oh, I see. That could cause deep embarrassment.
It completely destroys the patient's ability to be honest about her symptoms. If a woman is experiencing a severe postpartum complication, but is too deeply embarrassed to describe the physical details through her father-in-law, she will stay quiet.
And then the medical team ends up flying blind, and the patient's life is put at risk.
Exactly.
So what does this all mean for the patient? Are they just left rolling the dice, hoping they happen to get a provider who organically gets them? Or is there an actual system in place to fix this friction?
Well, this raises an important question, and thankfully, the text details evidence-based practice solutions. Hospitals are moving away from leaving this to chance.
Okay, good.
Nurses are now trained to actively assess their own personal biases. The solution isn't always a new piece of medical technology. Often, it's dedicating focused time to make diverse clients feel genuinely seen and heard.
It's about human connection.
Yes. Furthermore, there are strict step-by-step collaboration protocols being implemented with professional interpreters to ensure true, culturally accurate, informed consent is achieved before any procedure happens.
It really highlights how the hospital system has these deeply rooted structural and cultural challenges to work through.
It does.
But here's the massive twist the text brings up. Because of all these systemic challenges, and because healthcare costs are absolutely skyrocketing, care is increasingly being pushed out of the hospital entirely.
The shift is monumental. We are looking at a transition to what the text calls the perinatal continuum of care.
The continuum of care.
Yeah. Third-party payers, meaning insurance companies and government programs, have pushed hard for cost containment. This has led to early discharge policies, moving patients out of expensive hospital beds and into the community.
And a huge part of this community focus involves reaching incredibly vulnerable populations who simply cannot or will not come to a traditional hospital.
The statistics the text provides on this are staggering.
They really are. Take homeless women, for example. There are roughly 580,000 homeless people in the U.S., and women make up 39% of that population.
Which is a huge number.
And even more striking, of the homeless families with children, 84% are headed by women.
You also have incarcerated women, a demographic that has been growing twice as fast as men since 1980.
Wow, twice as fast.
Yeah, and they are often dealing with highly complex physical and psychological histories, including intimate partner violence.
And then there are immigrant, refugee, and migrant women. The text notes there are over 1 million migrant workers utilizing 175 migrant health centers.
And these women are dealing with intense fears of deportation, which keeps them far away from traditional hospitals.
Alongside severe physical risks from things like pesticide exposure and parasitic infections in agricultural work.
For these populations, traditional hospital-based care is often entirely inaccessible or actively avoided.
So how does the system adapt to that?
By rapidly expanding high-tech home care.
This blew my mind.
Yeah.
The text talks about conditions like severe preterm labor or hyperemesis gravidorum.
Which is extreme, relentless morning sickness where the patient cannot keep any food or water down.
Right. Patients with these conditions require constant IV nutrition and hydration, and they are now managing those complex, high-stakes conditions right in the patient's living room.
It is a radical shift in logistics, and it is heavily supported by the explosion of telehealth.
Like Zoom calls with doctors.
Yes, but far beyond that. We're talking about nurse advice lines, continuous remote video assessments, and even the deployment of high-definition telemedicine robots.
Robots? Really?
Yeah. These robots allow a highly specialized neonatologist sitting in a major metropolitan hospital to zoom in, manipulate a camera, and physically assess a distressed newborn in a tiny rural hospital hundreds of miles away in real time.
That is wild. You know, if you think about moving care from the hospital to the home, it's like a sports team going from having a home court advantage in the clinical hospital setting to suddenly playing an away game in the patient's living room.
That away game analogy is the perfect way to synthesize everything we've discussed today.
Because if you're a nurse walking into that living room, you are completely on the patient's turf. The lighting is terrible, the resources are whatever is in the kitchen cabinets, and the rules are dictated entirely by the family.
Exactly. If you are going to treat a patient in their own home, you absolutely must understand their family structure, their cultural beliefs, and their social vulnerabilities, because you aren't there 24/7 anymore.
The nurse is only there for like an hour.
Right. When the nurse leaves, it is the family who is left to administer the medication, monitor the IV pump sitting next to the television, and watch for life-threatening warning signs.
So if the nurse hasn't done that 15-minute CFAM assessment accurately,
If they haven't identified who the true caregivers are and whether they culturally understand and agree with the treatment plan, the entire system collapses.
it's a house of cards. If
Yeah.
the nurse hands the strict medication instructions to the patient, but the grandmother is actually the one in charge of the household and she culturally disagrees with the intervention, that IV isn't getting hooked up.
Home care completely removes the safety net of the hospital environment. It requires a profound, almost unprecedented level of trust, clear communication, and cultural synchrony between the medical professional and the family unit.
It really brings everything full circle for you listening. Healthcare, especially in the perinatal world, is no longer just about handing over a pill or hooking up a monitor.
Not at all.
It is about treating the whole person within the living, breathing ecosystem of their family and their culture. Identifying the culture isn't just a polite customer service strategy, it is a clinical necessity. If you ignore the culture, you are essentially ignoring the patient.
And as we look at where this is all heading, the text leaves us with a lot to consider. We talked about those high-definition telemedicine robots currently being used to bridge the gap.
Yeah, the robots.
But as virtual reality, remote biometric monitoring, and artificial intelligence continue to explode in capability, it raises a really provocative question for the future of medicine. Could we soon see a reality where the traditional maternity ward itself becomes completely obsolete? Will community care eventually evolve to mean that the most advanced medical technology on Earth is simply downloaded and delivered directly into your living room, completely removing the hospital from the birth experience entirely?
Wow. It really makes you think about that cinematic image of the hospital birth we started with.
It might just be a thing of the past.
The beeping monitors might still be there, but they might just be sitting on your own bedside table, surrounded by the people you actually want in the room. Thanks for joining us on this deep dive. We'll see you next time.